Future Pulse, investigating innovative cardiovascular research and the intersection of academic theory and clinical practice. I'm Dr. Thomas Nero, interventional cardiologist and Director of Cardiovascular Research at CAFC. Good morning. Welcome to Future Pulse. I'm Dr. Thomas Nero. Today, once again, we are going to be interviewing Dr. Peter Toth. Dr. Toth is the Director of Preventive Cardiology at CGH Medical Center and a Professor of Medicine at the University of Illinois and Adjunct Professor of Medicine at Johns Hopkins. He's also the outgoing President of the American Society of Preventive Cardiology. Finally, he's the star of a recent podcast on hyperlipidemia and cardiovascular risk here on Future Pulse. And I'm pleased that he consented or acquiesced or succumbed to another interview on the intersection of diabetes and cardiovascular disease. Thank you again, Dr. Toth.
Tom, thanks for the privilege of being here with you.
Boy, we have a lot to go over today. I'm reminded about a conversation that I had many years ago with Dr. Alfred Beauvais. At the time, he was the former president of the ACC and had taken over as editor of Excel. And he mentioned that cardiologists need to become diabetologists due to this significant overlap between diabetes and cardiovascular disease. Since that time, we've had a significant turnaround in that previously our treatments for diabetes really didn't improve cardiovascular outcomes. All of this seemed to start after the 2007 failure of rosiglitazone, which mandated cardiovascular outcomes data for all these medications. So it was a spectacular failure that's led to significant successes. And now we have two classes of medications that seem to improve these outcomes in SGLT2 inhibitors and GLP1 receptor agonists. Now we're looking at these medications for non-diabetic patients as well. So all this is preamble. I'm not really sure where to start. The first question is, I guess, as a mechanistic question, do you feel that the cardiovascular abnormalities that we're seeing are due to the insulin resistance and hyperinsulinemia, or do you think that they're due to the hyperglycemia, or are there other aspects at play?
Well, they're actually both. And actually, Dr. Bove interviewed me at ACC while he was editor of Excel, and he mentioned a great deal of what you just did. But I think apart from the fact that diabetes is, of course, an endocrine disorder, it is a cardiovascular disease. And it is rendered a cardiovascular disease by virtue of the fact that insulin resistance is so profoundly toxic to the cardiovascular system, but also clearly extremely toxic to the microvasculature, as evidenced by the fact that diabetic patients suffer the highest rate of adult onset blindness and adult onset renal failure in the world. And of course, it's associated with toe and lower extremity amputation, in addition to the fact that it dramatically increases risk for acute cardiovascular events secondary to accelerated vascular aging and atherosclerosis. So is it the hyperglycemia? Is it the insulin resistance? It's actually both. And let's break it down a little bit. So we have to put our biochemistry cap on if we talk hyperglycemia, because if you remember acid-base chemistry, which most people are not going to do, unfortunately, when glucose is highly available and as its serum level rises, you form advanced glycation end products, which are spontaneous glycation reactions. And the bottom line is that glucose can glycate proteins, enzymes, lipids, and it renders all of these glycated end products toxic. And they can accumulate in cells. You know, a very simple glycation product is hemoglobin A1C. Hemoglobin A1C is glycated at lysine residues, and it forms a very accurate marker of glycemic control. So you have a level of toxicity secondary to simple glycation, but then the insulin resistance is profoundly toxic. So why is that? Well, insulin resistance activates multiple pathways of inflammation. It induces a pro-oxidative state. It makes platelets more reactive. It induces endothelial cell dysfunction. It is responsible for the progressive steatosis of critical organs such as the liver, the pancreas, the epicardium. When we talked about epicardial steatosis at the last meeting we had. And all of this is clearly quite toxic. So let's break it down some more. When a patient becomes insulin resistant, if they're developing endothelial cell dysfunction, what happens? Well, endothelin 1 production increases, nitric oxide production decreases, prostacyclin production decreases, and there's vasoconstrictive input into the vessel wall, so blood pressure increases. And as the endothelial cell dysfunction progresses, then the endothelium becomes sick, tight junctions between the cells are loosened, and lipids have an easier time of transgressing the endothelial barrier, not only through transcytosis across the endothelium, but between endothelial cells. Now, something that is terrible about insulin resistance is it forms the so-called atherogenic dyslipidemia. Well, let's follow this. Adipose tissue is very, very sensitive to the development of insulin resistance. And when visceral adipose tissue, and by this I mean omental fat, perinephric fat, perimesenteric fat, when it becomes insulin resistant, there's no longer any braking phenomenon applied to hormone-sensitive lipase within the adipocyte. So there is constitutive triglyceride hydrolysis and free fatty acid release. So now you're flooding the portal circulation with free fatty acid, which is highly available. And the liver has a decision tree that it follows. And there are 4 disposal pathways for this excess free fatty acid, which it does avidly take up. Number 1, it can say, well, let's burn some of this as fuel within the mitochondria. And that's, of course, beta oxidation. Number 2, it can convert some of this free fatty acid to glucose via phosphoenolpyruvate carboxykinase. But now you're going to be increasing glycogen stores. And because the liver is insulin resistant and there's more glucagon available, you're also going to be non-specifically releasing more glucose from the liver, which exacerbates the hyperglycemia. And then if there's more free fatty acid coming in, the liver may say, well, let's just form triglyceride, package it into VLDL, and spit it out into the circulation, which is not a benign phenomenon. And then the 4th thing is it may just cry uncle, saturate all these pathways, and deposit the excess lipid as fat in the liver, which not only is toxic and pro-inflammatory to the liver and pro-oxidative, but it also exacerbates the hepatic insulin resistance. So this gets very messy. Now, we talked about how the VLDL increases, right? Well, the problem now is that the insulin resistance is a very potent inhibitor of lipoprotein lipase. ApoC3 levels increase, a well-known inhibitor of lipoprotein lipase. ApoC2 decreases, ApoA5 decreases. So inputs into the enzyme are promoting inhibition. Well, you have more and more VLDL flooding the circulation, but you can't break the triglyceride in it down. Well, this can't go on indefinitely. And that's where the safety valve comes in, and that's CETP, cholesterol ester transfer protein. And the cholesterol ester transfer protein does what it can to offload some of this excess triglyceride into the LDL and the HDL. But now you have a mess, because as you load up the HDL with triglyceride, it becomes a better substrate for the enzyme hepatic lipase, and you actually catabolize your HDL. And people with insulin resistance literally pee away their HDL and their ApoA1 because it winds up in the glomerular ultrafiltrate and it's excreted. The problem with loading LDL particles with excess triglyceride is that you, through the action of hepatic lipase, form more numerous, smaller, denser particles, which have biophysically an easier time of gaining access into the subendothelial space. Now, as the LDL particle gets smaller and denser, you also alter the 3-dimensional conformation of ApoB, which reduces its affinity for the LDL receptor, so there's reduced clearance at the level of the liver. And a smaller, denser particle is more apt to be oxidized in the subendothelial space by enzymes like NADH, NADPH oxidase, or xanthine oxidase, etc. Okay, now let's really get down to brass tacks, okay, and ask what else is insulin resistance doing that's really nasty. And the problem is now you begin to affect organellar function. So now you have the unfolded protein response evolving within the endoplasmic reticulum. And now the cell is really getting sick because the unfolded protein response leads to impaired functionality in the ER, and now the cell cannot appropriately replace proteins and enzymes. And you're going to exacerbate the hyperoxidative state because now the mitochondria are becoming dysfunctional. And this is a problem because now, as you know, the mitochondria are the powerhouse of the cell. They are responsible through the process of electron transport and oxidative phosphorylation for producing the ATP necessary to drive energy metabolism. Now, the problem is the terminal electron receptor, cytochrome oxidase, under these conditions, can participate in a process called redox slippage, SLIPPAGE. This is really a nasty thing because now instead of transferring 2 electrons to oxygen as the terminal electron acceptor, it transfers 1. And now you're producing superoxide anion hydroxyl radicals, and you potentiate the production of peroxynitrite. So these oxygen-free radicals run wild, and they are highly, highly toxic to the cell. If you really go deeper, there are also epigenetic phenomena that occurred with DNA methylation, telomere length reduction. As you can see, without me going further and further, this really is a profoundly toxic soup. And I think it helps to account for why these patients have such profoundly accelerated rates of vascular aging and atherosclerosis development and progression. It's amazing to me that despite this plethora of pathophysiology, if you simply use a statin, an ACE inhibitor, a low-dose aspirin, and keep the glycemic indices under control with newer drugs, you can profoundly influence outcomes. And I think that is such an extraordinary thing to be able to say in a clinical context, given all the things that go wrong in the underbelly of diabetes.
That was possibly the most brilliant summary that I've ever heard on hyperglycemia and insulin resistance. So, given all these things, and I agree with you that we're starting to crack the code here and actually improve outcomes, because for so long we had not been able to improve outcomes with our diabetes medications. One of the things you talked about at the beginning, though, was this question of glucose elevations and hemoglobin A1C, and whether or not the glucose elevations themselves or the spike in glucose is really what we should be looking at. And that perhaps the answer is not going to be hemoglobin A1Cs, but looking at continuous glucose monitoring. Do you have any take on the way that we're actually monitoring these numbers and how we're going to be looking at the results in our clinical trials based on the hemoglobin A1C or glucose?
Clearly, with the dawn of the GLP1s and the SGLT2s, we know that diabetes management, at least in terms of incretin metabolism and sodium glucose transport protein antiporting, a great deal of efficacy is to be had independent of A1C reduction. In terms of glucose versus hemoglobin A1C, there's no question that continuing to measure hemoglobin A1C in the clinical setting is extremely valuable because, of course, we want patients to have the best possible glucose control that they can achieve. We know that once A1Cs begin going above 5.5, you begin to see rising risk for both micro and macrovascular events. So A1C measures are very important. And obviously the SGLT2s and the GLP1s reduce A1C, but they clearly go well beyond simple glucose or A1C reduction. So I think A1C will always have a place in practice, particularly in primary care, where it is a critical feature of overall diabetes management. Now, do we worry if someone has these very significant glucose excursions on a regular basis and yet has an A1C of 7.2? I think the answer there is yes. It's good to get a handle on that because when glucose is very high, it is injurious, even if it's for short periods of time. But if it's consistent, it's going to incur damage. So the A1C number is still important, because the lower you take it, the lower the risk of microangiopathy. We know this from the United Kingdom prospective diabetes study. We know it from the Diabetes Control and Complications trial. We know it from virtually every prospective randomized study that's been done. You do reduce risk of retinopathy, nephropathy, and lower extremity amputation. And that's important because beyond having a stroke, which of course incurs fear, what else incurs profound fear? Going blind, for one thing. And then patients know once they go on dialysis, all bets are off because it's just going to wreak havoc on their body. And it's a terrible outcome. And we need to prevent that. And controlling A1C certainly contributes to that. So the SGLT2s, the GLP1s have profoundly transformed cardiovascular diabetology, profoundly. And I'm hoping that you next ask me what exactly it is about these drugs that makes such a difference.
So that's really funny you asked that, because I was just about to ask you what exactly about these drugs makes all the difference.
So let's start with the GLP1s. The L cell in your gut, it is absolutely amazing. And it doesn't just respond to glucose. It responds to bile acids, long and medium chain fatty acid. It responds to aromatic amino acids. Why? Because the L cell knows that the liver can interconvert sugars and amino acids and lipids on the drop of a dime. It just is so responsive to metabolic needs. And so is the L cell. And so the so-called incretin effect, where you get this large rise in insulin and GLP1 and GIP release with an oral glucose load, but you don't see that with an IV load. It's all because of the L cell releasing GLP1. Now, what does GLP1 do? On a very simplistic level, yes, we know that it stimulates pancreatic insulin secretion from the beta cell. It inhibits glucagon secretion from the alpha cell. It slows rates of gastric emptying. And because it puts the brake on glucagon, it's also going to put the brake on nonspecific hepatic glucose secretion and glycogen mobilization. So that's all good. But it does so much more. And actually, GLP1 receptors are expressed throughout the cardiovascular system. They're expressed in the brain. They're expressed in many, many organs. And so GLP1 is a critical modulator of metabolism and physiology in general. And so when you treat someone with a GLP1 receptor agonist, you decrease adhesion molecule expression along stressed endothelium. ICAM1, VCAM1, a variety of selectins, they're all downregulated. They render platelets less reactive. And we know that there are profound interactions between white cells, endothelial cells, and platelets. There's so much crosstalk between those three components that are such critical issues in atherogenesis. And all of them are affected by GLP1. Even white cells express GLP1 receptors. When you then look at experiments that look at inflammation, oxidation, the GLP1s reduce inflammatory tone, oxidative tone. And this leads to less oxidized LDL formation. The GLP1s, because they beneficially impact endothelial dysfunction, actually there is a correlation. There is observed reductions in blood pressure. And something that is emerging and definitely requires more investigation, it also turns out that if you inject a GLP1 intravenously, you can increase left ventricular ejection fraction. We simply think of that with the SGLT2s as improving left ventricular contractility and functionality. But actually, IV GLP1 experiments also show the same thing. So we may not be using the right dose, or perhaps we haven't observed it for long enough. But it also turns out that there are experiments that show that the GLP1s also promote natriuresis and gastrointestinal diuresis because they stimulate atrial natriuretic peptide release. So, research into this is clearly young, and we know that the GLP-1s are profoundly beneficial. At least 3 of them have shown efficacy now with liraglutide, semaglutide, and dulaglutide. And the LEADER trial was the first to ever show using liraglutide, a reduction in cardiovascular mortality as well as all-cause mortality in a diabetic population, simply given an anti-glycemic medication. And then with Sustain 6, we saw a profound reduction in stroke in just 22 months at 39%. But the reason I think Sustain 6 is also very important is because it showed a 36% reduction in need for revascularization and a 35% reduction in nephropathy progression. And again, people only correlate nephropathy progression with the SGLT2s, but Sustain 6 did show a 35% reduction in nephropathy progression on a 26% reduction in the overall primary composite endpoint. And Pioneer 6, using the oral formulation of semaglutide in a relatively short span of time of about 20 months, showed a 50% reduction in all-cause and cardiovascular mortality. So you're dealing with an intervention. You're dealing with a form of diabetes modulation that has extraordinary impact on the cardiorenal axis. And this is something that I think all cardiologists need to embrace and run with, absolutely run with. And then the SGLT2s, I think, have a little better uptake among cardiologists now, simply because of their profound impact on heart failure rates. Empareg using empagliflozin, when you're talking about a 38% reduction in heart failure hospitalization and a 40 and a 32% reduction in cardiovascular and all-cause mortality, that is an extraordinarily big deal in the heart failure world. And obviously, the SGLT2s are promoting glucose and sodium wasting. They're glucose uretic as well as natriuretic at the level of the proximal tubular epithelium. But the SGLT2s have also been shown to reduce intrarenal ischemia. They improve glomerular function. And there's also some early work showing that they improve podocyte function, which is probably why you see reductions in albuminuria and proteinuria. And then, of course, it's legendary now that the SGLT2s significantly improve left ventricular contractility, performance characteristics, bioenergetic profile. They reduce intramyocardial inflammation, and this leads to less fibrosis, less replacement of cardiac myocytes with fibroblasts and adverse forms of collagen deposition. And something that with the SGLT2s is in its infancy is their capacity to convert myocardium from free fatty acid-based metabolism to a ketone body metabolism, particularly centered on beta-hydroxybutyrate. Now, in a dysfunctional left ventricle, why would that be important? Because mitochondria have a particular love for beta-hydroxybutyrate. And in terms of ATP production per unit molecule, beta-hydroxybutyrate is the most energy-rich source that the mitochondria metabolize. And if you're improving the bioenergetic profile and now you're better matching the energy needs of the myocardium, of course it's going to perform better. Now, something that I think is going to be interesting to see is whether or not the SGLT2s improve electron transport, oxidative phosphorylation in general. And I have a feeling that they will, but we'll see. It's going to take a lot of work. But bottom line here is that using these drugs early is extremely, extremely important. I start them as soon as a patient is diagnosed. If you're diabetic, I don't care what your A1C is. I don't care what else you're on. I'm putting you on these drugs. And often I put them on both drugs. Why? Because the average diabetic has been diabetic for 3 to 5 years before they're even diagnosed. And they've been insulin resistant for between 5 and 10 years before they became diabetic. So if you think about this timeline of insulin resistance, plus the time they've been diabetic, according to the ticking clock hypothesis, they have already accrued a tremendous amount of cardiovascular and renal vascular injury that sets the stage for what's coming in the future. And you've got a lot of work to do to try to undo that and try to prevent any progression of this. And that's where these drugs, I think, are our best friend, because they so profoundly impact the entire spectrum of pathophysiology involved in the diabetic state. And especially when used together, the force will be with you.
It's interesting that despite all the actions of the GLP-1 receptor agonists that you discussed, and really this indication that they should improve heart failure, they don't seem to have so far. I am more intrigued about the ongoing tirzepatide trial with a combination GLP-1 GIP receptor agonist because of its anti-inflammatory component and possibly because of the renal vascular component that is thought to be involved here. But I've been surprised that they were so far failures as far as heart failure, but dramatically improved the other outcomes. And on the flip side, with the SGLT2 inhibitors, that they were so profoundly impressive in decreasing heart failure events, but have not really decreased vascular events. Or at least we haven't been able to see an indication from that from the larger trials.
No, you're not seeing a reduction in stroke and MI, which is interesting with the SGLT2s, given the spectrum of pathophysiology that they mediate. But that's why I think using these drugs in combination, where you get the best of both worlds, really is a good idea. And I think the earlier you use them, the better the patient will do.
There was some interesting small trials that actually have looked at the combination, and they've shown some sort of interesting results of the combination versus each of the medications individually. They saw was that the lipoproteinase decreased, but LDL didn't more than just on one or the other. It didn't really matter which one you were on. Weight levels dropped, obviously. ApoB levels did not change. Blood pressures dropped. It's intriguing. I'm wondering again, and we've discussed this a couple of times, what is the right metric that we're going to be looking at in order to try to see how they're doing? But perhaps the correct metric is just that they're living longer.
They're living longer. Never before have we seen reductions in mortality in diabetes trials. And here with two drug classes, we have. And they came within a couple of years of each other. And yet still the uptake has been relatively slow, which boggles my mind because often you hear the question, well, okay, so it reduced MI or reduced stroke, but it didn't impact mortality. I don't know if I'll use it. Well, now you're talking about drug classes that reduce mortality and reduce other very important endpoints for patients afflicted with diabetes, and still the uptake is slow. And perhaps it's because some physicians don't want to deal with diabetes, or some physicians say, well, they have a primary care doc or they have an endo, we'll let them deal with it. But actually, I think it's extremely important for all of us to just take the bull by the horns. And if there is a therapeutic deficit and we know that the patient's going to benefit from the institution of an SGLT2 or a GLP1, just do it.
You had asked the question earlier about why we're not having the uptake that we should, but we are having them in with the SGLT2s, especially in heart failure.
Yes.
Partially because we're able to show it not just in diabetics, but also in non-diabetics. And we're going to talk about that in a second. I do think that the fact that the ADA has now made institution of SGLT2 or GLP1 receptor agonists as a initial drug for diabetes, I think that that's going to go a long way. But I also think that the cost, though, is a hindrance, especially since many of our type 2 diabetics don't have good drug coverage, and they're still very expensive drugs.
They are expensive drugs, and cost is always going to be an issue. But even among patients with good drug coverage, they're underutilized.
Going on to the non-diabetic patient, certainly with the SGLT2 inhibitors, we are now using them routinely in patients with both heart failure with preserved ejection fraction as well as with reduced ejection fraction. And I do believe that in the future, we're going to be using GLP-1 receptor agonists for non-diabetic patients. Would you like to talk about what you think the mechanism of action is when you don't have the hyperinsulinemia and the hyperglycemia? Or do you think that there's always some aspect to those mechanisms in our patients, regardless of their diabetes status?
Wow. All right. So let's go through these numbers. When you look at a population of people who have an MI, 38% of all patients who sustain an MI have diabetes, whether they know it or not. Another 31% are pre-diabetic, and then the other third is normal glycemic. So two-thirds of the patients you see who come in with an MI have impaired glucose metabolism. Well, that's incredible. And it also tells me that if you screen absolutely everybody who comes through the door with an MI, you're going to catch an awful lot of impaired glucose metabolism patients. And most of them are untreated, which is why they had the MI in the first place, or inadequately treated. So that's an issue. When you compare women over 20 years of follow-up in the Women's Health Study who became diabetic during the course of the study and were diabetic for less than 10 years as the study went on, compared to the non-diabetics, they had a 2.7 greater fold risk of an ASCVD event. For women who developed diabetes during the study and had it for 15 years, for 15 of the 20 years, they had a 3.5-fold higher risk. And for women who were diabetic the whole course of the study, they had a 4.7-fold risk. So again, ticking clock. Insulin resistance is profoundly injurious. And once they're diabetic, things take off even more. And we see this rising gradient of risk as not only you progress from normal glycemia to prediabetes to diabetes, but also going from being normal glycemic and then being diabetic for 5 or 10 or 15 years or being diabetic for the full 20 years. It's a straight line up. Intercepting that early is absolutely critical. It's like anything else. The earlier you intercept, the more preventive you are. And that's the whole goal of cardiovascular disease prevention, is identifying issues early, treating them, and making sure that you keep people away from disease, because once they get disease, you're chasing a rabid dog and it's unpredictable.
Going back just a little bit, when we were talking about adding on medications and using multiple medications, a lot of people are using metformin first, obviously, because of convenience, because they're comfortable with the medication. And adding on a GLP1 receptor agonist or adding on an SGLT2 inhibitor to metformin, do you see that that would be as effective, or would you almost certainly go for the two newer drugs first and then move over to metformin in order to achieve euglycemia if they haven't been achieved with the other medication?
If it was a perfect world, I would prefer to use the GLP1 and the SGLT2s first, but it's not a perfect world. And so if I have to pick one and use it in combination with metformin, assuming that the patient's renal function allows me to do that, or that they tolerate the metformin in the first place, then I'm going to go where I'm going to get the biggest bang for the buck and manage the patient the best possible way, given financial or other constraints. But if it was a perfect world and they had great insurance, my preference would be to move forward with the GLP-1 and the SGLT2 first because of their extraordinary clinical efficacy. You look at metformin, and people touted it for a long time. And for a 300-patient subgroup analysis out of the UKPDS, for it to reduce MI by a third, nowadays, if you were to take a 300-patient post-hoc subgroup analysis into an ACC session, they would laugh you out of the room, right? And it was never shown again in prospective randomized studies. And when you look at the meta-analyses, it also shows basically neutrality. So bottom line is, yes, I suspect that metformin would contribute to microangiopathy risk reduction because of its effect on A1C. And we know that microangiopathy is pretty responsive to A1C. But in terms of managing hard ASCVD cardiovascular risk, I don't have a lot of confidence in it. Now, there is a trial that is underway that is being done through the VA system in Denver that's going to prospectively test whether or not metformin impacts risk for cardiovascular events. And that is recruiting now.
That will be a very, very interesting trial to look at. And I think it's going to be important because we're not going to be able to get that data in other ways. The current trials that we're going to be having now for non-diabetic patients, because they're not going to have background metformin therapy as part of the trial or as an option in the trial. Just to take a sort of a sidestep, one of the beneficial effects of both these medications, but more so for the GLP1 receptor agonists, is weight reduction. And there's been a lot of discussion about the effect of weight on cardiovascular disease, and that the weight reduction is going to be an important piece. And with the newer drugs, the ability to get a weight loss of almost 15% of their body mass is, I think, going to be a profound change. Before we get there, do you think that it is the medications, or do you think that the weight and decreased adiposity is going to be driving some of these benefits?
Yeah, it's both. All of the benefit is not going to be from weight reduction and relief of insulin resistance because of the plethora of other mechanisms by which the GLP1s and SGLT2s work. Plus, the majority of patients do not lose so much weight that they profoundly influence the insulin resistance. And the weight loss with the SGLT2s is much more modest. There can be some, because if you're blowing off glucose, you have less glucose to burn. And so that is helpful. But certainly for patients who are very successful with concomitant weight loss, they're getting a double whammy in terms of benefit.
I do believe that if you are going to be choosing these medications, that they really should be looking at them long term. And it's not just going to be the weight reduction, and once they achieve that weight reduction, that we stop the medication.
Oh, no, never. No, that's a great point. Because actually, long term, as people age, they tend to gain that weight back anyway. But bottom line here is, I don't think anyone believes that it's just a manifestation of the weight loss.
So when we're talking again about the weight loss and the decreased cardiovascular risk factors, we're skipping over some of the more important pieces of our armamentarium with diet and exercise. And one of my concerns is that as we achieve some of these profound benefits, that we're going to stop talking about the benefits of diet and exercise, and that with weight reduction, you only get a 10% improvement in cardiovascular outcomes, but with diet and exercise, you get a 50% reduction in cardiovascular outcomes, and that it's still going to be a greater improvement than almost any of our other pharmacologic agents. And yet we don't really talk about it or focus in on it. And even in these trials, there's no part of these trials where they're saying, oh yeah, and you have to be doing these other things. It's almost as if we're creating a moral hazard here by giving the patients the weight loss so that they don't have to do these other things.
Well, I think that if they want to maintain the weight loss, they certainly do have to do those other things. If they don't, the weight eventually is going to go back on. That I see a lot. So you do have to couple it with sensible diet and an exercise regimen that a patient can enjoy. And that's the critical thing. Most treadmills turn into clothes hangers in 4 to 6 weeks. People have to find something they enjoy. I swim 4 days a week and I lift 3 days a week. I'm an avid practitioner of Kung Fu. So I get my licks in and I try to do something every day. And I think a good adage is probably the only day you shouldn't exercise or engage in physical exertion is the day you don't eat. Your heart is like a racehorse. It wants to move, right? Your heart wants to go. It's a racehorse. And muscle wants to be contracted. And the more it's contracted, the greater the energy efficiency, the greater the mitochondria density, the greater the recovery for ATP, the cytosolic phosphorylation potential. So I think emphasizing these things to people is extremely important.
I hope it's not lost in the mix here, because people are certainly listening to Twitter and watching what's happening with Ozempic and Mounjaro, and they're not really discussing these other things, which I think are critically important. A couple of last questions. You had discussed a bit about myocardial fibrosis and the benefits of these medications potentially on decreasing myocardial fibrosis, which I do think is part of what we're going to be looking at as far as the improvement in ventricular function, both for HFpEF and for HFrEF. Do you think that this is a mechanism that we need to be looking more at especially in our diabetic patients because of the increased fibrosis that we're seeing?
Yeah, diabetic cardiomyopathy really is founded on fibrosis. It's founded on increased ventricular scarring, adverse forms of connective tissue deposition, abnormal forms of connective tissue, which leads to a very stiff, non-compliant ventricle, which then gives rise, of course, to the diastolic dysfunction we see in heart failure with preserved ejection fraction. Those are going to be longer studies because obviously, if you're improving elasticity, you're replacing adverse forms of connective tissue with normal forms. You're allowing for regeneration, if you will, if it happens, of cardiac myocytes. That's a long-term proposition. And I think it's going to take a very special study to show this. And it's going to take a company willing to make the investment and go for the long pass here to be able to observe it, because it took a long time for those patients to develop that diastolic dysfunction. It's not like you're going to unwind it in a year. So I think that's going to be a longer term proposition. But given what we know so far, especially with the SGLT2s, that would be a profoundly important study to do.
The other issue on that is trying to make that diagnosis. And we can't make the diagnosis of intramyocardial fibrosis. We make it as a presumption.
It is.
But do you think that we should be doing better with our imaging, that we should be using CMR and where we can identify some myocardial fibrosis, or that we should be looking at strain imaging to be able to diagnose this better?
I think so. Obviously, when you're talking about cardiac MR, it can get challenging to get a prior auth through just because you're thinking outside the box and you're looking at something that the reviewer at the other end of the phone doesn't necessarily understand. But yes, I think more precise means of imaging for loss of compliance, loss of elasticity, the so-called classic diabetic cardiomyopathy, independent of ischemic cardiomyopathy, we definitely need to do a more precise job of identifying those patients. Now, I think part of the problem is identifying is one thing, but I think doing something about it is something entirely different. And we've been helpless in the face of this. I mean, we don't have any good treatments for it, but hopefully we will, especially with perhaps a drug like an SGLT2.
As we're planning research going forward, having sub-studies that are including these populations so that we can start getting that data together and making the propositions that we then have to, that will lead to the establishment.
I did just misstate something. And the misstatement was, I retract what I said. We have no means of treating heart failure with preserved ejection fraction because obviously Entresto can impact that. What I meant was it's very difficult to be able to document reversal and seeing histologic improvement in diastolic dysfunction. So anyway, I just wanted to refine that statement.
Consider it done. I've had such a good time talking with you over the past week here. What research are you looking at now that you find particularly interesting? What research are you saying, oh yeah, I think this is really cool. I think that this is going to be the next big thing. We've moved from essentially the lipid era and we've moved into the inflammatory and metabolic era. I think that we're going to be moving into a antithrombotic era that's going to be upcoming. What are you looking at? What do you think is going to be the next big thing?
I find the work of Dr. Charles Sirhan at Mass General to be quite profound. And he is working on anti-inflammation, naturally occurring anti-inflammatory mediators. And so compounds like protectins and defensins and merisins, small lipid mediators that actually bring inflammation to a resolution in a highly controlled and systematic way. And being able to harness some of that is going to be absolutely extraordinary. So if I had a chance to catch Dr. Sirhan at a meeting, I would definitely want to sit down and talk with him for about a half an hour and pick his brain, because I think what he has done is truly extraordinary and ingenious. And I think it has the potential, anyway, to profoundly influence so much disease. Because when you think about it, inflammation drives cardiovascular disease. It drives neurodegenerative disorders, renal disease, muscle disorders. You name it, the entire spectrum of disease has some basis in inflammation. The list is extremely long. And if you were able to situate controlled resolution of inflammation without precipitating increased risk for infection or autoimmune disease, this would be an enormous step forward.
I'm very intrigued, and we had talked before about the inflammatory pathways and how important they're going to be. Well, Dr. Toth, this has been once again a wonderful, wonderful time going over insulin resistance, hyperglycemia, and the new medications that we're going to be using. And I really hope that this podcast will go a little bit in the way of getting a greater uptake of this with our colleagues so that we can really get these drugs into the patients that really need them. So thank you so much.
Tom, thanks for the privilege of being with you here today. Really appreciate it. Thank you.
Thank you.